When the world woke up to Anthony Bourdain's death by suicide, none could believe that a man with such a successful career could take his own life. Bourdain's death got many talking about mental health and one of its likely catastrophic events, that is, suicide.
Depression is a mental illness. It's classified as a mental disorder.
So what are the signs and symptoms that one can identify in themselves or in one of their relatives or loved ones whom they suspect that this is possibly somebody who could be suffering from depression?
You'll always hear the relatives say that their patient has been withdrawn. They don't want to mix freely with the other people. They'll say that the patient has a very low mood, whereby if you look at the patient's facial expression, you'll realize that the patient is sad. Some will tell you that the patient has refused to eat and without an apparent reason. So they say the patient has no appetite. Some will also tell you that their patient may have committed suicide or is threatening to commit suicide.
To put it more simply, it's characterized by sadness that cannot be explained, and it goes on for at least more than 2 weeks. So we are not talking about sadness of 2 hours, accompanied by a low mood, accompanied by what we call anhedonia, simplified as lack of interest in things that a person enjoyed before, or lack of things that a person needs to do, like house chores or work that needs to be done at their workplace, or even hobbies and sports that the person enjoyed before, pleasurable activities. Also, difficulties in sleeping, either sleeping too much or sleeping too little, what we call insomnia, lack of appetite, feelings of worthlessness, feelings of immense guilt, and hopelessness, and then this can eventually end up in thoughts of suicide. So the person can either have ideas of suicide, or they can actually be planning and having a strong intent on completing a suicidal act. Depression can either be a chronic illness or a recurrent illness. So chronic means that you can end up having it for the rest of your life. And then recurrent, you may be having remissions at some stages of your life whereby it goes away and then it resurfaces again. So you may find that you are in this battle with this illness for most of your life or for the rest of your life, or maybe for a very short time just after a major event in your life, and then you get better. Depression is very common. In fact, if you look at the WHO classification, among the disorders that are causing disability now, immediately after heart diseases, depression is next. That's in disorders that are causing disability. So we are talking about a lifetime prevalence of around 17%. So we are saying that 17% of people at one point in their life, in the population, will suffer from depression. That's really common, yeah, and that's a lot. Yeah. Depression can either occur in a disorder called bipolar illness, whereby in bipolar illness, the word bi for two, you are either too high or you are too low. So when you are too high, we say you have a manic episode. When you are too low, then we say you have a major depressive episode. So somebody can be having depression within that spectrum of illness. But there are people who will never suffer the highs. They'll just have depression alone. Then you can also have depression after having a baby. What we have, the postnatal depression. Though even after having a baby, you can also have psychosis, which is a bit different from depression. But you can have depression, or you can also just have postpartum blues.
What are some of the things that people do at home just before coming to hospital, just to try and seek medical help or seek care for their person who's suffering from depression? What are some of the things they do just to try and manage the situation even before they come to the hospital?
It usually differs from one community to another. We have some communities whereby they always think that it's evil spirits. So when they think about the evil spirits, they'll take the patients to the church or to some people who pray. We have some spiritual people who believe that they pray for people with such conditions and they get better. Some go to herbs. We have some herbal medicine that they usually take. Some even believe that they have been bewitched, and so they will take them to witchcraft. And when now they realize there's no improvement, maybe through someone who may advise them that the hospital can manage. So they end up coming to the hospital, but sometimes you find that when the symptoms have really gone extensive.
Depression most of the time will run in families. So you'll find that if somebody has someone in their family who has a mental illness or who has depression, they are also likely to suffer from depression. So it can be genetic. Then it is also seen a lot in people who have suffered a lot of what we call life events. And these life events are things like loss of a child, loss of a spouse, loss of parents at a young age, a major traumatic event in life, or major traumatic events in life can be road traffic accidents, can be sexual assault, can be an attack by robbers in your house, and can also be death of a spouse. I think I've said that, yeah. Then other things can be, depression can also occur in people who are using substances, alcohol abuse, or even just use of any other psychoactive substances.
Do the patients have insight? Do they know what they're suffering from or why they have the signs and the symptoms that they exhibit?
Yes, sometimes you find that when a patient comes to you, those ones who have been, if it's a relapse, they may know that it is something they have. But if it is for the first time, some usually don't really know. And even if you ask the patient why they are in hospital, they tell you they were just brought. They didn't know why they were brought. But as you continue interacting with them, just as I've told you, one-to-one talks. And then now when we come to the group, and they also hear the other patients talking about it, they identify the symptoms they have. So that will help them now to get an insight to their illness.
As nurses, you spend a lot of time with the patients, and during this time, because you're the ones who give the hands-on care, during this time when you're spending a lot of the time with the patients, by default, you also spend a lot of time with the relatives. What do you do to engage the relatives or the guardians of the patient so that they work with you as the caregivers and they work also with the patient throughout the healing journey or throughout the treatment process for depression?
You may find that some of the reasons why these patients are sick could be originating still from either at home, from school, from the community, or it is something that is inherited from the family. So depending on the contributory factor to the condition of that particular patient, we usually educate the relatives so that they know the possible contributory factors to depression.
Most of our patients in rehab, or many people who are using substances, they also have an underlying mental illness. So they end up in substances because they are trying to self-medicate. Or maybe somebody once experimented with a substance and they kind of felt better, not really knowing what is happening to them. So they get deeper and deeper into the use of a substance. But what we know is that most of our clients, a very big percentage, whether they are using alcohol, whether they are using cat, whether they are using cannabis, cigarettes, or whatever, heroin, at the end of it all, most of them, when well investigated by a psychiatrist, they'll be found to have an underlying mental illness. It can be anything ranging from schizophrenia to depression.
When they have come to the hospital, what kind of help do you offer them as a specialist in psychiatry? What help do you offer the patient and also just the relatives so that they understand what exactly is happening?
If maybe in the interview or history taking, you found out that this patient is suicidal, then you'll need to put this patient on a card we call suicidal caution card, so that that patient is under close observations so that they don't commit suicide, because they are likely to commit if they are not observed closely. You help the patient in feeding, because some, when you try to feed them literally, they sort of, when they taste the food, sometimes they'll feel the taste and it may appetize them. So at least they'll be able to feed gradually. You have to continue just talking to the patient, making the patient feel that she's wanted, sitting closer to the patient, showing concern of whatever condition the patient has, so that the patient feels someone is caring and may one time now decide to open up, at least to start talking. We have something we call group therapy. In that group therapy, we discuss, we help the patients choose a topic of their own, which is pertaining to the conditions that we have in the hospital. So in the process, when now they choose that topic, we help them choose a chairman of their own, so that you are raising their morale, you are raising their self-esteem, so that when during that time the patient also starts seeing these ones are patients and they can be able to be given a responsibility.
Depression can be managed in many ways. We can manage it using medication. We have our different classes of medicines that we give. It can also be managed psychologically, whereby now the therapist will be given by a psychologist. So we can have what we call cognitive behavior therapies or any other therapist that a psychologist feels is best suited for that kind of a person. And then the other therapy that we find important is just the social support. So you may find a doctor talking to the relatives to give the person more support, or talking to a spouse to give the person more support, or if it's a child, talking to the parents to give the child more support. So in mental illness, when we are treating a patient, our treatment basically in a nutshell is what we call the biopsychosocial model. So the bio is for the medications, the psycho part is for the psychological therapies that a person actually gets, and then the social aspect is the social support that a person gets. And social can range from just somebody giving you support all the way to economic help, because we know that finances can also be a big part of people having mental illness.
Some relatives, you find that they can leave the drugs with the patient. You may really not know if that patient is taking medication or not. So we usually encourage them that they should be in custody of that medication and supervise and make sure that the patient is taking the medication. They should also involve them in the family activities, because some usually think that when someone is depressed, they cannot contribute to to anything in the family.
Is there hope that they can be managed and they'll get better?
Yes, there is hope. And they have done well, because they come to the clinic and you find someone who was really depressed. They are able to laugh with you. They'll be able to tell you how they are doing. They are able to do their activities at home, and they have done so well.
People come for management sometimes when it is too late. Then it will mean maybe managing will be a bit difficult. But again, somebody can come to you with depression, but they don't have the resources to actually be able to take care of their depression. So it's varied. You cannot say it's easy and you cannot say it's very hard. But what we know is that if you're getting your medicines, if you're getting your social support, and again, you're getting your psychotherapies, all of them, remember again, we have very few psychologists in this country. And if it's in a government facility, we can say that we are really having a shortage of psychologists to take care of our clients. So what we are saying is that if you have the adequate care, if you get the adequate care or the optimum care, then we can say managing is easy. But again, we may be working in a scenario where, is it really easy for you to get all the adequate care that you need? Then that would mean that managing your depression will be a bit difficult.
If the patient is on medication, they must continue with that medication until the doctor says stop. We also tell them that they have to learn to cope with the situations, because life is never a straight line.
If somebody is depressed and they're having a low mood, they're crying all the time, they can't sleep well, then it means they actually can't attend to their duties. If they're a mother, they can't take care of their children. If they're a worker, they're a doctor, or whatever it is, the place of work they go to, then they can't go to work. And if they are forced to be at work, then they really can't be productive. So ranging from the person just being unwell, to lack of productivity, and to economic loss in society. Actually, as you know, WHO classifies depression as one of the major illnesses that bring about disability, but also that result in huge economic losses to a country.
I know many people would think, this is just a phase. Somebody's just low for a while, they'll get over it, but they may not really see or understand the gravity of the situation of depression, because we've known people who've been depressed for a while, they commit suicide, some even commit homicide, then they commit suicide themselves. Why do you think as a society we don't think that depression could be really something bad, but if it's caught early or if it's identified early, then something can be done about it? Why do you think it's underestimated?
My child ran away from school and is in the house. If you tell the child to go to school, the child doesn't want. And you are not taking that effort of looking for any interventions from anywhere. So you find that they neglect their children in the house, be it a husband, be it a wife. They are neglected. So it is, he just keeps quiet there. And you don't want really to dig and find out. If you can't, you seek for advice. So that is why you find that some people stay with their problem and some even end up committing suicide.
First of all, we can't take mental illness lightly. Because it causes a lot of torment on the person who is suffering from it. Actually, the people who take it lightly is not the patient. The people who take it lightly are the people surrounding the patient, either the relatives, the friends, or any other person. Again, as we always say, depression is not like when you've just suffered a road accident, a road traffic accident, you're bleeding from everywhere and everyone will sympathize with you immediately. There's really almost nothing that you can see on the person apart from what they are complaining about. And commonly in my practice, we found that many people actually take it for granted and they take the person not really so seriously. I mean, if you're having a low mood, go do something to lift it up. But we are saying that if you have a low mood for more than 2 weeks, sadness, feelings of worthlessness, hopelessness, and you are thinking of committing suicide, or if you know somebody who is thinking of committing suicide, it's something very serious and it should be taken seriously. The person is really not just, it's not a joke. Yeah.
How do the families take such a diagnosis of depression, especially when something that could have contributed to the illness could be family related? How do they take this news that you deliver that, your patient so-and-so has depression, and we suspect from our assessment, our mental assessment, that it could be family related or originating from the family? How do they take this?
We've had cases whereby the relatives accept, because if you take them through whatever contributory factors to the illness, some really take it positively. But, human beings differ. We have some parents who believe that they are superior, and what they say is what must be done. So they will always think that their child cannot control them. They need to control the child. So it becomes a bit difficult to make them actually understand that this child, we are the contributory factor to this problem, and we need to address where we usually go wrong according to how the professionals have identified.
First of all, they should understand the person. Then secondly, apart from understanding the person and seeing where the person is coming from, let them seek help. They can seek for help from a psychologist, they can seek for help from a psychiatrist or a counselor, and depending on who can see them. And then the other thing is that if they need to be assisted, like children, again, we know that of late also, more and more children are getting depressed, and more children are committing suicide, or people who are below 17 years. So the social support that you can give at that time is to listen to the person, hear them out, and ensure that you seek medical advice.
That's where we wrap up this episode of Health Digest, where we have been looking at issues around childhood, psychiatric illnesses, and depression. I've been your host, Dr. Mercy Korir.